Much, everyone. I think to save time, I might as well straight away start with the presentation. And the stuff is very easy. I think I was here since last 1 hour, and there was very, very good presentation. And I really enjoyed my stay here. And I hope you like this presentation also. And I'm going to talk about role of combination therapy in the management of hypertension, and particularly emphasizing on the power of a single pill. When we say pill, it usually means Viagra, but this is actually hypertension pill. This is my disclosure. I am presenting on behalf of SERL, and the relevance of SERL, you know, they make many antihypertensive drugs combination, and that is why I'm here. Otherwise, I have no financial implication with SERL, and contents are entirely my own. And these are the 4 agenda items, and we will go through the burden of hypertension. I think in every lecture on hypertension, you see these slides. But you know, this is the #1 killer indirectly through cardiovascular disease. And if you identify various factors as just single factor, hypertension is undoubtedly the biggest killer. And very importantly, this killer is preventable. In Pakistan, you know, in the total incidence of the hypertension prevalence, depending upon what criteria you use, actually there is some difference of opinion and the methodology. Even if we follow the conventional method 140/90 and use the clinic readings, about 1.3 billion people in the world are hypertensive, and in Pakistan, 18% adults and 33% more than 45, they have hypertension. And through ASCVD, it is the #1 killer. But very unfortunate reality is we have massive population suffering from hypertension, and many of them, they do not even know, because it's an asymptomatic disease. And in our society, because of poverty, because of lack of health education, people would visit a doctor only if they have symptoms. Since this disease does not cause any symptom and there is no routine checkup, so they remain undiagnosed. Those who are diagnosed, they're not always treated. Many of them would consider it just a temporary rise and blame something they ate before that, and they would not seek treatment. And those who are treated, they are also not at goal. They are taking a pill, a certain dosage, whatever was prescribed on maybe 2 years ago, and they're just taking a pill without having any follow-up, so their blood pressure remains high. So the actual objective of treating blood pressure remains unachieved. And in Pakistan, of course, the situation is extremely poor. Less than 10% people with hypertension, they are at goal. So unless you are at goal, for example, if you have some work at Karachi, you have to get there. Reaching Sakhar would probably not be enough. So this is burden. We all know hypertension is very, very prevalent and mostly undiagnosed or undertreated. So the next session is diagnosis and evaluation. The diagnosis is very easy. I think it is one of the easiest things to diagnose. Now imagine if you're treating a case of autoimmune disease. It would take maybe several series of tests before you are sure what you're treating. Similarly, treatment will also be very, very complex. You try various agents, and then you finally achieve your goal. Whereas in hypertension, all you have to do is to measure blood pressure carefully, but you have to do it in an unhurried way. Patient must be resting for 5 minutes and do it with a calibrated apparatus. And do it more than once, and these are the readings based on office reading or the other readings, you could make a diagnosis of hypertension. If facilities are available, I think all these patients should have these tests to know what is the cause of hypertension and if there is already some hypertension mediated organ damage. And you should also evaluate the patient to see if there is any comorbidity which could actually affect the choice of your treatment, like asthma. So this is the detailed evaluation. And after this evaluation, you may be dealing with two types of patient. One on the left is stage 1 hypertension with no additional risk factor. And in this patient, the 10 years risk of developing CVD may be very low, like maybe less than 5%. So there is no hurry. You could start with simple treatment and patient will be okay. And you may call him after 6 months. But on the other extreme, somebody with stage 3 hypertension with multiple risk factors and maybe with diabetes or already with atherosclerotic cardiovascular disease, that patient is already on the edge. You must deliver your best to save his life. And there may be many grades and shades in between. So the treatment and the entire approach has to be individualized. Somebody you may like to call him after 7 days, another patient you may call him after 6 months. So this was the diagnosis and evaluation. Only in some cases, those who have resistant hypertension, those who have truly refractory hypertension, those who have secondary hypertension, definitely would require many more investigation. So why to treat? In health professionals, this question is already answered. We know why. Because we know untreated hypertension kills. And with treatment, we can save those lives. But for people, those people who are without symptoms, somebody might have come to you for some other reason. You check blood pressure, it is high. So I think where you have to talk to the patient, explain to him why treatment is needed. So I think this one simple slide will tell you why treatment is necessary. Now if you see these graphs, within the normal range, this is the normal range. Even within the normal rate, lower blood pressure means lesser mortality. And as we move on to the upper normal range and then the abnormal range, this is the cut point where blood pressure diagnosis is made. There is any 20 by 10 millimeter mercury rise in blood pressure increases the double the incidence of cardiovascular death. So this is actually very alarming. Of course, the relationship is linear. Now, interestingly, if we control the blood pressure, if we bring it back to the normal, then the risk of atherosclerotic cardiovascular disease is brought back to normal. So this is very interesting. So another point, I think aim of treatment should not be to just bring it to 140 by 90. I think lesser is better because within the normal range, it is better to bring it back to physiological level, 120 by 80. So this one slide was, I think, good enough evidence that we need treatment. Without treatment, stroke, heart failure, dissection of aorta, ischemic heart disease, chronic kidney disease, the incidence of all is very high, depending upon the duration and degree of hypertension. And with successful treatment, the incidence is brought down very effectively. Of course, it depends how regular patient is in medication. It is possible that patient is taking treatment, but he misses the treatment and then there is the rise. So I think somebody who is particular about the medication, probably all these complications are prevented. So this was agenda number 3 done. Now the last agenda item, which is actually the main focus of this presentation, how to treat. First of all, there's lifestyle changes. DASH diet means that you have to advise the patient that the simple diet, I think DASH diet can be translated into simple language, simple diet. A diet which is not very rich in fats, is not very rich in salt, and the fats are unsaturated, coming from the vegetable source, Mediterranean style diet, and the meat should be mostly, I think, poultry or the seafood. And of course, less in quantity. Then we have to work on the weight. There's a lot of emphasis on weight. Overall weight is important, but particularly important is your waist. So I think you need to work on your weight. So these things, of course, then exacerbate it. Patient may be taking some medicine for some other reason, maybe a good reason. Patient may be taking non-steroidal anti-inflammatory drug or an immunosuppressant for autoimmune disease, or patient may be a smoker, or they may be aggravating. So you must address all these factors and see if you can take them off the patient. So there is, I think, very good chance that you could bring down blood pressure by 20 by 10 with just lifestyle changes. So if lifestyle changes, alone do not work. Then you add on medical therapy. First of all, these are the nice guidelines. Younger than 55, you start with RAS blocker, and older than 55 or ethnically black, you start with amlodipine. Start with small dose, like if you're talking about valsartan, 80 milligram, moving to 160, then 320. And if you're talking amlodipine, 5 milligram, and then 10 milligram. About 30% will be controlled, and those who are not controlled, you combine them. These are the nice guidelines. It is best to combine RAS blocker, either ACE inhibitors or ARBs with amlodipine. A combination would control another 30%. And I have highlighted them together because we usually use combination because that makes patient life very convenient, and that also translates into better compliance. Better compliance translated into better outcomes. And those who still not under control, we can give it triple drug combination with hydrochlorothiazide. So I think about 70% will be controlled. There will be some patients who are still not controlled, and then we add mineralocorticoid receptor antagonist or any drug. You must have noticed that there is no mention of beta blocker here, but beta blocker not entirely out. The nice guideline says that at whatever level you feel the need for beta blocker for a compelling reason, existing ischemic heart disease, heart failure, angina, migraine, and the other condition, you could add beta blockers, usually small dose, usually as add-on therapy. And the European Society of Cardiology and Hypertension, they go a step further. They say, since in majority, single agent does not control blood pressure, or at least it does not bring to the desired level, and if we if you keep increasing the dosage, it causes side effect, might as well start with the combination. So these are the latest guidelines issued in 2018, but revised in 2024. So start with the combination medication, ACE inhibitor or ARB, either of the two. You know, because of the better side effect profile, these days we are prescribing ARBs more often than ACE inhibitors, but both are acceptable. Along with that, either calcium channel blocking agent or hydrochlorothiazide. So this make a combination, and then only those patients who have mild stage 1 hypertension and those who are aged, frail, single agent may be tried. So in majority, you will use 2-drug combo, amlodipine with valsartan or valsartan with hydrochlorothiazide, like that. So I think another 30% will be controlled, and then in some cases you would use 3-drug combination, and in some the 4th line. So I think there is emphasis on starting with 2-drug combo, because these are European Society of Cardiology, because that translates into better compliance and better results and outcomes. So why they emphasize doubling, adding another agent rather than doubling? This is the slide. If you have one agent and you increase, you have further lowering, blood pressure lowering effect. But if you add another agent, then the effect is much more pronounced. The blood pressure lowering effect is multiplied, whereas side effects are only simply added. I think the side effect profiles, actually some of the side effects are canceled. So I think this is the example. And this is the rationale of combining amlodipine with valsartan. Amlodipine, most prescribed calcium channel blocking agents, metabolically neutral, afferent vasodilator, and valsartan, most prescribed ARB, corrects activated RAS, and it causes afferent vasodilation, potent BP lowering effect, and BP lowering plus cardiorenal benefits, quality plus quantity. I think these two, you have the quality as well as quantity in one pill. So why not use the goodness of both the drug in one pill? So this is, I think, one more slide. I'm going to explain why this combination works so well. If you give amlodipine, and if you see the graphics, there will be blood pressure lowering effect because amlodipine works very fast. It is not dependent on anything. It just goes to the vessel and dilates. So blood pressure comes down, but immediately, whenever there is vasodilatation, body perceives it as something negative and it activates its RAS. And once RAS is activated, the initial blood pressure lowering effect is reduced to a certain extent. So with the RAS activation, what is the solution of RAS activation? You add a valsartan. So rather than doing it late, you might as well combine valsartan with amlodipine to start with. So blood pressure will be further reduce. Again, come to that. So power of two, Wilbur Wright and Honorable Wright can do wonders. No, you are not brother. One is visionary and analytical, the other is creative and innovative. That is why this combination of valsartan and amlodipine is so good. So with one single pill, you could have blood pressure lowering effect of 30 by 15. So I think this is, and about 70 to 80% it's effective. One more slide. Amlodipine is otherwise very safe drug, but it is notorious to cause pedal edema, especially when you touch 10 milligram or go beyond. About 70% people they develop edema. Though it is not very harmful, but it is not nice to look at, people would definitely be worried. So if we add, why it causes edema? Because it primarily causes afferent dilatation. Now please see this slide. Blood vessels going into the capillary bed, they are dilated. Those going out are not. So the pressure in the capillary increases. The fluid is pushed out of the capillaries, and that causes edema. But when we add valsartan, the efferent vessels are also dilated. So blood flows very smoothly through the vessel without causing increased intracapillary pressure. So the chances of edema are reduced. So combining valsartan and amlodipine increases your blood pressure lowering effect, but reduces edema. I think that will solve the problem. Similarly, when you use albumin, amlodipine alone, there is increased intraglomerular pressure that might actually increase albuminuria. But when we add valsartan, efferent vessels are also dilated, glomerular filtration is increased, but not the glomerular pressure. So I think similarly, we can have three-drug combination by adding hydrochlorothiazide. There are some hard nuts to crack. These are that I think Shafiq Jima is also going to talk about the resistant hypertension mistake. I think he will cover. But before you label somebody as a case of refractory hypertension and resistant hypertension, must make sure that patient is taking his pills. So that is the most common cause of resistant hypertension. So BP goal, I think I'll make it simple. In every patient, your goal should be 130 by 80 or around this number. Particularly in diabetics and patients with CKD, and in elderly, you have to accept high systolic pressure and low diastolic pressure because of the arteriosclerosis. In general population, 140 by 90 or less is acceptable. So I think using just one pill, you can control such a menace, such a big killer, hypertension, in about 90% of the cases. So that was all for me. This is my channel. If you're interested, this lecture and many such lectures are available on my channel, Medicine, and you, I think, and this is a free. Thank you very much.